Thank you for calling in on the ASPN and PSPS COVID-19 webinar. We are going to wait just a few minutes for others to join in. The webinar will begin momentarily. Hello, thank you for calling in on the ASPN and PSPS COVID-19 webinar. We are going to wait just a few minutes for others to join in. The webinar will begin momentarily. Hello, thank you all for calling in on the ASPN and PSPS COVID-19 webinar. We are going to wait just a few minutes for others to join in. The webinar will begin momentarily. Hello, thank you for calling in on the ASPN and PSPS COVID-19 webinar. We are going to wait just a few minutes for others to join in, and the webinar will begin momentarily. Hello, thank you for calling in on the ASPN and PSPS COVID-19 webinar. We are going to wait just a few more minutes for others to join in, and the webinar will begin momentarily. Hello, everybody. Thank you for calling in on the ASPN and PSPS COVID-19 webinar. Now let me introduce Dr. Tim Deere, Chairman of ASPN.
Well, thank you, Lakin, and thank you everyone tonight for tuning in to join us on this collaboration between ASPN and PSPS to talk about a very important issue. In December 2019 in Wuhan, China, an outbreak was arising that spread throughout the world. This pandemic now is a real issue for us as we think about the best patient care, the best ways we can protect our physicians, our advanced practitioners, our nurses, our people on the front lines, as well as have the best job for our patients. A week ago, we created the COVID-19 Task Force, chaired by Dr. Krishnan Chakrabarty, and we decided that we would have a series of webinars, this being the first and hopefully the most informative one. We're going to actually try to give you great information over the next hour to help you to do the best job you can in this terrible time of crisis. But lastly, we also want to come together as a family of people trying to help the world. Those are our goals. Tonight, this webinar is brought together by two societies that created the task force. I'm going to introduce our first society with Dr. Dawood Syed.
Thank you very much, Tim. Again, I'd like to reiterate the great words that Dr. Deere just mentioned about this epidemic that we're all faced with. I'd like to briefly just start this with introduction of our society, the American Society of Pain and Neuroscience. So When Dr. Deere and I decided to found this society almost 2 years ago, one of our real visions was that to create a society where all our initiatives are really focused on improving patient outcomes, education, research, and innovation. And one thing that we really wanted to do is we wanted to get a lot of like-minded individuals where we could, at that time, our thought was, the technology and innovation in pain and neuroscience changes so rapidly. We really need a nimble society that can work with these therapies so that we can innovate and implement these very quickly for our patients. I had no idea that one of our first major initiatives would be to form a strategy around how to deal with a global pandemic. But I'm really thankful that we have ASPN right now because we were very quickly able to rally the troops and create this webinar for up to, we think, maybe close to 2,000 people will log in to join us today from around the world. So I'd really implore you guys all to take a look at learning more about ASPN. Our website is listed here at aspenpain.com. Membership is very, very, very cheap and not very cost prohibitive for most. Our pledge to you, though, is during this pandemic that all the educational materials that ASPN will put out will be free of charge to members or non-members.
Good evening, everyone. I'd like to introduce you to the Pacific Spine and Pain Society. We are a fledgling society. We've only been around for 3 months, founded in January 2020. We currently have 275 active members, and our president currently is Dr. Eric Lee. I'm the president-elect. Dr. Amir Delfan is our vice president. Lisa Krupp is our treasurer, and Michael Young is our secretary. Dr. Jason Polk, who you'll hear from in just a bit, is our chair. We are focused on issues surrounding spine, surgical care, and pain care overall. We represent the Western United States with all the states you can see listed there. Our primary goal is to develop a platform for all of these different specialties to collaborate and cross-pollinate different ideas to improve patient safety, efficacy, and access to research, advocacy, and education. Please join us at www.pacificspineandpainsociety.com. With that, I'll turn it back to you, Tim. Thank you.
Thank you, Ramo. I greatly appreciate your work, and I know you previously worked in the SARS epidemic. So here's our agenda for this webinar. We have Dr. Chakrabarty, the chairman of our task force, who is not only an MD in interventional spine at UCSD, but he's also a virologist. I know very little about virology, although I'm learning from Dr. Chakrabarty. Then we have Dr. Jason Pope, who is actually an expert in telemedicine and many other things in the world of pain, and the founder of PSPS. Dr. Erica Peterson is one of my trusted neurosurgical colleagues that I go to often for advice in neurosurgery. She'll talk about some of the issues surrounding when do you do surgery and when do you not, what's elective, what's urgent, what's not elective. Those are some of the things we'll hear about from Erica. You've already met Dr. Nadu, and he'll talk a little bit more. And then our first speaker actually will be Dr. Jasmine Marcelin, a physician from infectious disease, our first member of ASPN who's an infectious disease specialist. And thank goodness tonight we have her with us, because all the questions I'm getting almost hourly from colleagues around the world involves how do we handle different issues with infectious disease. So with that, I will introduce my colleague and trusted advisor on infectious disease, Dr. Jasmine Marcelin.
Thanks, Tim. Today, I wanted to give a brief primer on COVID-19, including how it's transmitted, how we can protect ourselves, the current state of disease, and what we know right now about treatment. The respiratory virus responsible for our 2019-2020 pandemic is called the Severe Acute Respiratory Syndrome Coronavirus 2, or SARS-CoV-2. The virus is a single-strand enveloped RNA virus with spiked projections on the outer surface of the envelope. These spiked projections are responsible for the name coronavirus because corona means crown in Latin. The disease caused by this virus is called coronavirus disease, or COVID-19. Symptoms generally start appearing about 5 to 6 days after infection, but the incubation period generally ranges from 2 to 14 days. The virus is transmitted by close person-to-person contact with large respiratory droplets expelled by coughing or sneezing. If you are within 6 feet of a person coughing or sneezing, you may be at risk for being infected. Virus particles can persist on surfaces for up to 72 hours, and certain high-risk procedures may result in aerosolization of the particles, although the virus itself is not transmitted airborne in the way that we traditionally think about measles, varicella, or tuberculosis. It enters a new host by contact with mucous membranes, that is the nose, the mouth, the eyes, and that's why we say to wash your hands and don't touch your face. Now in the next slide, we'll talk a little bit about how to protect ourselves. Besides washing our hands and avoiding touching our face, you can clean and disinfect frequently touched objects and surfaces such as doorknobs, light switches, or cabinet handles. Older adults and people with serious chronic illnesses should avoid non-essential travel and avoid putting themselves in line of contracting the disease. For the general public, there is no real need to wear a face mask if you are well and you do not have any symptoms. However, healthcare professionals should be wearing PPE whenever evaluating potential COVID symptoms. Patients with potential COVID symptoms. So recommended PPE for those situations include a N95 respirator or a surgical mask if that's not available, face shield, gloves, and a gown. So there is a shortage of PPE that is current across the country, and many organizations are becoming creative now with how the respirators can be reused or maintained for extended use. Some of the resources at the end of this webinar will have links to more information about PPE reuse. The CDC also has some excellent guidelines summarizing next steps if you are exposed to somebody who is ultimately diagnosed with COVID-19. An important note is that you should stay home if you're sick. This is sometimes hard for us to do as healthcare professionals, and we think that we can work through any illness, but as we will see on the next slide, the symptoms of COVID-19 can resemble other respiratory viruses, so coming to work with these symptoms may mean you could be putting your patients and your colleagues at risk. The next slide outlines these symptoms. The most common symptoms of COVID-19 are fever, cough, plus or minus sputum, and shortness of breath, although many other symptoms can occur and overlap with several respiratory viruses, including influenza. So now we will briefly discuss a comparison between bacterial pneumonia and COVID-19 pneumonia. In hospitalized patients presenting with pneumonia, it's important to try to differentiate between a possible COVID-19 pneumonia, which does not benefit from antibiotics and needs specific isolation precautions, and a bacterial pneumonia, which typically does not require isolation precautions and requires antibiotic treatment. I won't go into too much details of the testing, but because we know that there is a slow uptake of testing nationally for various reasons, many centers are using specific testing criteria or not testing at all. So if tests are available but limited, a reasonable testing strategy would be to limit to hospitalized patients with COVID symptoms, healthcare professionals with any symptoms, and high-risk outpatients like the elderly, diabetic, or other immunocompromised conditions, immunocompromised patients, etc. In the next few slides, we will discuss the severity of this illness. So how bad is it really? In the world today, we have over 400,000 cases and 18,500 deaths in total, with 52,000 cases and 677 deaths occurring in the United States as of 5 p.m. Central Time today. Looking at China, where we have the bulk of our information and most of our worldwide confirmed cases, we see a vast majority of the individuals will have a mild disease and recover, about 14% with severe cases, and about 5% will become critically ill. Overall, about 2.3% of all infected people died from COVID-19, which is the case fatality rate. And in the next slide, we'll look a little bit at the case fatality rate, a little bit more detail. So in case 2.3% seems like a small number, and since we did a lot of comparison to influenza in the early reports of COVID-19, it's reasonable for us to look at these two side by side. So here we see that yes, the elderly are disproportionately affected by severe disease and are more likely to die, but you will see significantly higher case fatality rates of COVID than influenza in every single demographic group. We also know that people can spread the virus while asymptomatic, although the majority of transmission may occur when a person has symptoms. So we must take this pandemic seriously. So how do we treat it? At this point, there are no specific medications recommended to prevent or treat COVID-19, but there are some that are being studied as we speak. And in the next slide, we'll talk a little bit about some of these therapies. So what do we know about these drugs so far? The first one on our screen will be remdesivir. This was initially developed for Ebola, but has activity against coronaviruses in vitro. It inhibits the RNA polymerase, and in vitro studies demonstrated some activity of remdesivir against SARS and MERS. It's currently available for clinical trials across the country and the world, and was previously available for compassionate use as well, but in the last 24 to 48 hours, the manufacturer has stated that they will no longer be using this, making it available for compassionate use, instead focusing on clinical trial enrollment, and they will consider expanded access use for children and pregnant adults on a case-by-case basis. We're waiting clinical data before making recommendations on use. So hydroxychloroquine and azithromycin. In vitro activity against COVID-19 has been seen. Chloroquine is being used in China based on anecdotal data. There are clinical trials that are ongoing. There was a recently published report about azithromycin in addition to hydroxychloroquine, and that's caused quite a stir in the medical community. The study itself was observational, and it was neither blinded nor randomized. And the report discussed eradication of SARS-CoV-2 in the combination group with less eradication in the monotherapy and control groups. However, because of the small size of that observational study and some possible failures not identified, it simply demonstrated that we need more data rather than highlighting a new cure. So let's also not forget the potential adverse effect with this combination, including QTC prolongation, unnecessary use of antibiotics and their associated side effects, and run-on hydroxychloroquine prescriptions leading to inadequate supply for people who have rheumatologic conditions who need this. If you're on Twitter, there's a fantastic thread written by the Society for Infectious Disease Pharmacists president, Dr. Polk, that really gives a good summary of some of the reasons for caution with that study. We don't know where hydroxychloroquine will land, but more studies will help us to figure this out. There is an ongoing clinical trial of hydroxychloroquine as post-exposure prophylaxis by University of Minnesota that's currently enrolling. Lopinavir, ritonavir has some in vitro studies suggesting activity, but early clinical reports are inconclusive. And one recently published randomized trial showed that there was not any benefit, no difference in mortality, time to improvement, or viral shedding. It's being investigated in further clinical trials, but this drug has a lot of drug-drug interactions, adverse events, especially GI-related side effects. There's questions about ACE inhibitors as well, and what we know is that SARS-CoV-2 binds using the ACE2 receptors, and so concern that ACE inhibitors and angiotensin receptor blockers may increase the risk for more severe disease due to upregulation of ACE2 receptors. So far, this concern is only theoretical, and the European Society of Cardiology Council on Hypertension, American Heart Association, and American College of Cardiology have all come out to say that they do not recommend discontinuing ACE inhibitors or ARBs in your patients. Similar theoretical concern for upregulation of ACE2 receptors with NSAIDs and ibuprofen potentially causing increased risk for more severe COVID disease. And so far, again, this concern is theoretical, and the FDA has not modified their package insert, neither has the WHO recommended against using ibuprofen. Finally, steroids. There has been a compilation of data for RSV, SARS, MERS, influenza, and all of these have shown that there is no benefit to adjunctive corticosteroids, and in some cases, increased mortality and other adverse events like psychosis and diabetes. So there is a recommendation to avoid using corticosteroids unless there is a different indication for it. So remember, supportive therapy is the cornerstone of treatment. Treating symptoms, ventilation, support if needed, IV fluids, etc. if a person is admitted to the hospital. But the best thing that we can do is to help to reduce the burden of this infection in our communities is on the next slide. So this next slide is showing the curve associated with the hashtag flatten the curve. We've seen this curve before in other epidemiologic situations. The yellow curve on the left represents development of the pandemic without measures that slow the rate of infection and overwhelm the healthcare system. The purple curve on the right represents the development of the pandemic with these measures to slow infection rates. So let's remember that in the 1918 influenza pandemic, the responses of the cities of Philadelphia and St. Louis could actually follow these curves. Philadelphia made the unfortunate decision to continue with plans for a parade for their soldiers during World War I in the middle of the pandemic and became one of the hardest hit cities in the US with more than 12,000 people dying in 6 weeks. St. Louis, however, canceled their parade and their death toll was less than 700. So social distancing made a difference in how the influenza pandemic played out in those two cities back then and is making a difference in how different parts of the world are impacted by COVID-19 today. We can absolutely hope for results from our ongoing clinical trials and be innovative in supportive care measures and PPE preservation, but ultimately our best shot at making a difference is going to be effective social distancing to blunt the rapid spread of disease and prevent overwhelming of our healthcare system, which would be catastrophic. So for this to work, everyone must do it. This is a public health emergency, and that means we have to stop thinking about what is important for us as individuals, like parties and play dates and concerts and spring break, and think about what is important for us as a society, like protecting our elderly, our disabled, our immunocompromised, our homeless, who are the most vulnerable to serious complications.
Well, that was certainly amazing, and that social distancing part was just really striking to me. The Philadelphia versus St. Louis story, and I think we can all really learn from that. So some of the things we're hearing about treatment is encouraging, but nothing's as impactful as following the social distancing and preaching that to all of our friends and neighbors. But as pain medicine physicians or neurosurgeons, I know we have several on the webinar. The webinar is totally full, so people are having trouble getting on because we've overwhelmed it. We may actually do this again in a week or so just to make those who couldn't get on tonight. But one of the things we need to think about is the impact on pain medicine and what we can do to save our patients and our colleagues really additional turmoil by making sure we do a great job. No one's better to speak to that than the chairman of our task force, my good friend and certainly a noted PhD in virology as well as physician Krishan Chakravarthy. So Krishan, thank you very much.
Thanks, Tim. First of all, I just want to thank all of the clinicians, both in the US and all of those folks that joined us internationally on, a tireless amount of work that goes in. I think this webinar is a starting point for our field to start working together in a call for unity. I think there's definitively, you look at the number of folks today, there are folks that represent academic centers, and then there are folks that are in their own private practice where monthly paychecks means keeping their business open and keeping their staff hired. So as a field, we're going to have to understand that as the different agencies come with their guidelines through CMS, CDC, and FDA, we have a very challenging time ahead to make sure that those guidelines are capable and implementation of those guidelines can be done by everybody. So we have to adapt smart strategies, and we have some amazing panelists tonight that are going to talk to you about everything from screening to personal protection to implementing telemedicine. But we're going to also have to make important decisions in figuring out what procedures are elective, urgent, or emergent. And those decisions are going to help us navigate what's going to happen in the next 2 weeks, a month, 3 months, and 6 months. You hear this often, and I think there is a real philosophical debate. I think without a doubt, pain is one of the most important parts of the medical field and what we're treating. but we are at a critical inflection point where social distancing and the allocation of those resources are going to make the decisions on how the trajectory of this disease process is going to go forward. And within that, there's a field of thought that at some level, as more folks that are getting the infection, that you're going to be promoting herd immunity. But it's not just the peak that we need to be concerned about. Each individual, as physicians, as our staff, we need to be cognizant of the fact that it's also the rate of rise that you're getting towards the peak, because that's going to determine how best we're using our resources. And hospital resources are going to dictate how well we can treat the folks that end up in those ERs or that are really sick with ARDS or pneumonia. So I am calling out to all of our colleagues today that this is not just a 3-month effort or a 2-week effort. We have to work together. We have to adapt our guidelines to the needs of the time. And I encourage all of you to work with all of us in these different societies to try to implement some of these strategies. But it's certainly not one webinar today, but a collective effort that's going to go forward. So with that, I have the pleasure of introducing a close colleague of mine, Dr. Naidu, who was a past professor at UCSF and who had done some really interesting epidemiological work. And I think what he's going to tell you is going to be really important, because this is the practical aspect of taking the science and putting it into your practice tomorrow. And hopefully we're going to follow these with some of the guidelines going forward.
Thank you, Christian. Yes, 18 years ago, I was hired by the World Health Organization European Office in Copenhagen, Denmark, as a communicable disease fellow, and my primary task was to do the statistics and epidemiology of SARS. So here we are 18 years later with a virus that shares 97% of its genotype. I'm located in Luxbury, California, here in Marin County, just north of San Francisco. Greetings to all of you from all over the world. Now, I'm going to talk to you about how to protect yourself as a healthcare worker. All right. And the grim facts are this. In Italy, 8% of all COVID-19 cases are in healthcare workers. It's estimated that 20% of responding healthcare workers in Italy have COVID-19. In one hospital alone in Bergamo, Italy, 25 of the 90 physicians were diagnosed with COVID-19. Not only is that tragic, but what it tells us from a system standpoint is that they lost 30% of their workforce. So now they're at 70% capacity, unable to take care of the data who need help, critical care, etc. Many cases in Italy and Wuhan were nosocomially transmitted to patients, to otherwise healthy patients from other COVID patients. And then when they went home, they transmitted the disease to their families. And we don't know the actual numbers, but we're talking about at least hundreds, if not thousands, of individuals have been infected this way. So as a healthcare provider, it is your responsibility to protect yourself in order to protect your patients. Now, Jasmine's already shown us flattening the curve, which actually is a schematic that came out of a CDC paper in 2007, where if the United States endured an influenza pandemic, what would be the best way to mitigate risk? And I'm sure you've all seen this in the news and on Twitter and social media. And a couple of things I'll point out for the importance of a pain physician or surgeon is this. Some of us who have a business perspective on things, because we own private practices, et cetera, might look at these two curves and look at the area under the curve and say, well, the total number of infections in both curves is actually fairly similar. The difference is, at least in the pink curve, it gets done with sooner, and in the gray curve, it's protracted. Maybe it's better from an economic standpoint to get all the infections out of the way and then get back to business so I can start making money again and support my staff, et cetera. But the problem is that won't work. And the reason for that, as I'll get into, is the mortality rate. And if we're trying to sell health as a practice and we end up being a transmitter of the disease or increasing mortality, that's a horrible business plan. The case fatality rate with this disease, COVID-19, is estimated anywhere from 0.1 to 3%. And the reason we have a wide range is that the denominator is unclear because of asymptomatic carriers. Now, among all COVID-19 patients, it's estimated that 20% actually end up in the hospital due to comorbidities, age, et cetera. And let's look at the cases that go to a system where the cases are below healthcare system capacity. So examples include South Korea and Singapore, where they've been able to adapt to these patients. The estimated in-hospital mortality is around 5%. Now, if we compare that to systems where the cases extend beyond the healthcare system capacity, the in-hospital mortality rate is estimated around 90%. So examples include what we're seeing in Italy today and what we saw historically with Wuhan in the last several weeks. Now, what can we do as pain physicians or surgeons in our communities? Well, one of the critiques I have about this graph is that dotted line, which shows you the healthcare system capacity, is not a straight line. There are things that can actually raise it, and there are things that can actually lower it. So, for example, in China, in Wuhan, they built several hundred-bed hospitals in a matter of days. Here in California, Governor Newsom opened up 2 abandoned hospitals for the state. President Trump has put in those 1,000-bed warships outside of San Diego and New York, again, to increase capacity. And one of the things we've done locally is we've actually converted our clinic in ASE into a triage for orthopedic fractures. So we can divert those cases away from our community hospital in order to keep more critical care beds, ventilators, emergency room space for COVID-19 patients. Now, as a pain physician, here are recommendations. We recommend postponing the non-essential procedures and surgeries, and Dr. Syed and Peterson will go through that in more detail. Use telemedicine and telehealth. Dr. Jason Polk will go through that as well. For those of you in private practice, as I am, do whatever you can to reduce overhead and maintain revenue. Look, This is not easy. This really hurts. I've had some of those difficult conversations in the last 2 weeks with my staff on how to manage them. So everyone's hurting here. Protect personal protective equipment for various healthcare settings, whether it's in your clinic, the ASC, or the hospital. Because if in your community this disease starts to spread rapidly, you will need that protective equipment immediately. And then consider expanding your healthcare system capacity in your own community like we have done here in Marin. So what do you do if you deem a patient essential for your care? Examples include an injection you need to do for a patient who can't walk, or you've got a pump refill to do. How do you proceed? Well, you can triage or screen patients with questionnaires. You can take their temperatures. But the problem is this, #asymptomatic carriers. There are individuals who can be pre-symptomatic for several days, shedding virus, giving it to everyone around them, and yet they'll pass this triage screen with ease. So triage screening isn't the best way to deal with SARS-CoV-2 or what becomes COVID-19. If you're going to do this at all, do it outside of your healthcare facility. If you're doing the screening, once they're inside, it's too late because they've already touched all the fomites, the doorknobs, the handrails, et cetera. So we do set up tents outside of our ASA and our clinic to screen patients prior to coming in. Once they come through, we distance them. So we keep all of their friends or relatives outside in their own cars, or if they do come into the waiting rooms because they must, we keep them spaced at least 6 feet or 2 meters apart. Now, the last bullet point is testing. In an ideal world, we would be able to test every single person. So I would know you have it or you do not have SARS-CoV-2. And if you have it, go home, quarantine for 14 days. If you don't have it, come on in. It's business as usual. I won't get into all the failures that we have here in this country with HHS and CDC and FDA, but we are behind. And so therefore, we cannot do that rapid testing. And what frustrates me is that polymerase chain reaction testing is 37 years old. It's older than the advent of the internet. We should be able to do it, but here we are without these tests. So since we don't have it available, assume all individuals are infected. Now, as Jasmine mentioned, SARS-CoV-2 requires contact and droplet precautions. For those of you who are in face-to-face proximity or perform aerosol-generating procedures, like myself, anesthesiologist, I'm sure there are a lot of anesthesiologists on the line, you should take airborne precautions in these situations. Examples, like I said, intubation, bronchoscopy, or if you're triaging. The CDC has these posters available. I'm sure you've seen these in your facilities. Pay attention to them. It's important to know when to do what in which setting. And for those of you who do airborne precautions, you have the option for an N95 mask, which you should try to maintain throughout the day as long as it becomes contaminated, and then close the door for those isolation cases for sure. Now, protective or personal protective equipment is something that you should consider to be a rare commodity. So only use it if it's something that is going to help you and your community as far as a solution. We have to store it. As you know, in New York City, there's concern about running out of it. The president has enacted powers to help manufacturers get more of this available. One of the things we've learned from SARS and from Ebola is that healthcare workers can become infected because of improper donning and doffing of PPE. So please take a look at these instructions, even though all of us do this all the time and we think, oh yeah, just put a gown on, a mask, no problem, then just take it off. If there's any breach in any one of these steps, you can infect yourself and infect everyone around you. And I think the most important slide is on the right-hand side here, where you can see how to remove the equipment. In this example, they showed taking off the glove and gowns, and then take the goggles off from the back of the head, over your head, throw them away, and take off your respirator or mask from the back of your head and over. Don't touch up here in the front, take off your goggles, because potentially you could have been sprayed with droplets. And then step 4, of course, wash your hands afterwards. I'll add a step 5. Before you walk into your house, have a clear pathway to your shower, decontaminate yourself, shower, put those clothes in the laundry, don't infect your family when you get there. And this is one of the major concerns going around the country and around the world. Now, this paper came out last week out of New England Journal of Medicine regarding how long do these viruses last on surfaces. And so it compared SARS-CoV-1, which is responsible for SARS in 2002 through 2004, and SARS-CoV-2, which is responsible for our current COVID-19. And I'll direct your attention to the bottom right-hand corner, in which you can see the half-life of these viruses on plastic and stainless steel, two surfaces ubiquitous in a healthcare setting, is about 6 to 8 hours. So if you think about 5 half-lives to get down to a viral load of 3% of its original, we're talking about 30 to 40 hours. So a day and a half, 2 days, and if the viral titers are large enough, we're talking about several days remaining on fomite. And this is very concerning for all of us in a healthcare setting. Now, the good news is the virus membrane is susceptible to our usual agents, such as alcohol, cavity wipes, diluted bleach, Windex, soap and water, and even sunlight. So whatever you've got available should do the job. You just have to be meticulous and periodically decontaminate or disinfect. Now, this last slide is a summary slide. It's wordy, but it allows you to print the screen or print it up when you have a chance later on tonight. But I'll direct your attention to the bottom line. All the steps I've talked about already, you've heard, but in this litigational society we live in the United States, I think it's important we all have a disclaimer about the possible transmission of SARS-CoV-2 in your facility. You need to protect yourself and let patients know that this risk exists, just like you do for any procedure you do. And the last thing I'll say is, if you're going to provide care, comply with all of these steps. It sounds somewhat draconian, but if you choose 1 or 2 of these Swiss cheese slices, you're not going to get the job done. Really follow all these steps to protect yourself and protect your patients. I appreciate your attention. Thank you, and I'll hand it back to Tim.
Ramo, that was certainly very impressive. And your work with SARS 17 years ago, it's unfortunate that we're here again 17 years later and we're still in the predicament of being overwhelmed by the virus. I learned to do ultrasound for peripheral nerve replacement about 6 months ago. Before that, I used nerve stimulators to do it. So I learned a new trick. And so Jason Pope, who used to work with me in West Virginia, now is quite the leader in California, taught me about telemedicine some time ago, but I didn't ever employ telemedicine until this Monday. And I converted all my office patients to telemedicine. And I have to say, it went quite well. It's much safer for everyone, safer for the patient and for yourself and your staff. So whenever possible, I would acknowledge that that's the way to go moving forward to protect us all. So we asked the expert in the area, Dr. Jason Pope, to give us
Well, thanks, Tim. I certainly appreciate everyone's attention. And again, as been described throughout the webinar thus far, it really is empowering to know that we are a community of people trying to care for patients. And this is an absolutely challenging time. So we all have really relied on in-person visits to do the physical exam and to do the assessments to make sure that we take care of patients appropriately. And because of the social distancing, because of the veracity and the transmission associated with this virus, I think it's really critical that we implore opportunities to take care of patients electronically. And as we get started, I have a few disclaimers, and I think it's important to note that this is not gospel. This is absolutely just a guide, and I encourage you to look at your own local coverage determinations. We are going to talk a little bit about the 1135 waiver, which provided some authority surrounding the loosening of some of the CMS restrictions surrounding some of the components to telemedicine and what that means, including telehealth specifically. And again, certainly at the end of the day, we want to make sure that what we're doing is of medical necessity for patients, because I think that's really critical. We don't want to do telemedicine just in the midst of doing telemedicine. It needs to be done appropriately. And so going through this, we're going to see that there are a few different opportunities to provide care for patients. And I think one of them is essentially these non-face-to-face services. That is telemedicine. Telemedicine is essentially described as an exchange of information through an electronic communication. And with the day and age that we have with iPhones and Skype, and certainly telephonic communication is something that's important to consider as well. But I think really critically, we want to be mindful of the fact that there are three basics associated with telemedicine. One is virtual check-ins. The other one is e-visits, and then the other one is telehealth visits. And so when we think about these telehealth visits, I think that's the area where a lot of us are going to start employing these audio-video strategies to take care of patients, because I had a full day of practice today. As Tim describes, we've converted all of our patients over the last week and a half specifically to these televisit opportunities, because patients need to be seen. I mean, we take care of a very vulnerable patient population. We can certainly do a lot of these things remotely. And again, to try to reduce the likelihood of transmission, taking care of ourselves and taking care of our patients and our families, it's really critical to try to use these things. So again, telehealth is really the use of these opportunities. So these electronic communications, specifically audio, video, and we need to use these resources to our disposal. And again, keep in mind also that normal judgment is critical, because all these things still apply. And we can talk about coding of these strategies. I think that may be somewhat out of the scope of this communication. And I would refer you to a lot of the guidances that are coming out through CMS. This is an evolving strategy. It's very fluid right now. And so I would encourage you daily to log on to CMS and take a look at how these things may apply. But certainly when we think about the different types of these electronic communications, they're again broken up into three classes. It's this virtual check-in strategy, it's the e-visit, and then it's also this telehealth strategy. And again, the telehealth strategy is a strategy where we have this 1135 waiver where we're allowed to do certain things without concern of the OIG's oversight on the benefit or the need for having established patients as having a relationship with a patient prior to initiating this. And we'll go through that in a later slide. But we'll start with the virtual check-in. And the virtual check-in is essentially something that you can do via secure text message or telephone or patient portal. And it really is an opportunity to check in with the patient to see how well they're doing. This is something that absolutely has to be initiated by the patient. Now, that obviously means that you have an opportunity to educate the patient that there is an opportunity to engage with their provider this way, but it certainly can include telephone, text message, secure email, and patient portal. And a lot of us use electronic medical records now. I think gone is the day of using paper. Honestly, as I've gone through my practice and the buildup of this, we are paperless. And so we really pride ourselves on communicating with patients through their smart devices. And you would be surprised here in Sonoma, where people are used to drinking out of wine glasses and IPA glasses, they still have smartphones. And these smartphones are used by people from the ages of 18 to 90. And it takes a little coaching to figure out how to use the device. But I think it would be remiss to think that our older patient population that we commonly serve in this vulnerable state, that they don't know how to use these devices. So it's absolutely something that you can educate them on doing, and they likely already have some historical perspective from it. These virtual check-ins, it's critical to note that it does require documentation, so that's really important. And it's something that is not limited to rural areas. Some of the e-visit scenarios, which we'll talk about later, and the telehealth, prior to the waiver, it required a site of service that was not the patient's home. This is one of those things where you can, even before the 1135 waiver, contact with patients through their home. The strategy would be, again, that it has to be initiated and consented to by the patient. And typically the way these virtual check-ins work from a reimbursement perspective is that it's accumulation of amount of time, typically on a 10-minute interval, but largely when we think about a payment structure associated with this, the check-in needs to occur without the previous 7 days from an EMN visit, so an encounter, and it can't lead to an encounter related to the communication within 24 hours of that communication. So I think largely there are some rules to live by, and I have a conclusion slide which will describe some of these things, but there's resources that we have available to us through CMS, which I would encourage you to look at. When we think about the next stage of this, and the next layer of complexity, is the e-visits. And these e-visits are oftentimes accomplished through patient portals. Again, it's not limited to rural areas. It is for patients that have an established relationship with the practice. It does require that you do document that permanently in the patient's chart. And then there's layers of payment surrounding the total length of time over a 7-day period when you're in communication with the patient. And this can be done, again, either telephonically, it can be done audiovisual, it can absolutely be done through the patient portal. And it's one of those things too that it's based off of 10-minute intervals. So essentially 0 to 10 minutes, 10 to 20 minutes, and 21 minutes up, there's a different code associated with that. And this is something that not only the provider can do, but it's also something that your administrative or ancillary staff can also accomplish, because there are separate codes associated with that. I think the one that people are most interested in during this broadcast is probably the telehealth. And so we'll spend a little time on the telehealth strategy. And this was the part of the waiver, this 1135 waiver, where people really had an opportunity to assess patients remotely, because we want to try to, I think, physically distance ourselves from people to try to reduce that transmission. And so as of March of this year, based on this pandemic that we're seeing, the CMS, I think, created some laxity surrounding the site of service for the telehealth strategy. It used to have been done at a designated facility. Now it can be done at home. It does require audio video communication. And so there are a lot of different resources surrounding development of audio video. We're obviously using one right now. Some of them historically have had an opportunity for a HIPAA compliant way of making sure that the communication was secure. Because of the interest in taking care of patients remotely, there is, again, laxity associated with the HIPAA compliance surrounding the audio video for the encounter that's required. And so people are using various things from Skype to FaceTime, to Zoom, to a variety of different things. And I think there are systems being built specifically designed to help patients in a HIPAA compliance strategy that may be more integrated with practice. These things, importantly, are going to be reimbursed just like you would if the patient was sitting across the exam room from you. So now that doesn't mean that you stop paying attention to the requirements associated with the coding. So doing a 99213 or a 99214 or a 99212, those coding requirements are still in place, but you're available and allowed to do it through a telemedicine strategy. And again, audio video is required. There has been, again, laxity associated with, can you see new patients with this strategy? Under this current guidance, the answer is yes, you can. Certainly, if you feel like a patient needs to be seen for this within the pandemic. That's a discussion that one needs to have individually with the patient and also with the risks. I think it's really important to appreciate that. And I think everything that we do when we take care of patients needs to be captured in that as much as possible. And then we have some data kind of surrounding a summary of this along with the coding that you can use. There is, if you do this during this pandemic strategy, when you do the telemedicine, you do not have to put any modifiers, no GT modifiers. You don't have to put in a 95 modifier. You can code it like you would otherwise, but you do have to put in the encounter that you did accomplish this through a virtual appointment through telehealth, and that really is all that's required. I think I would encourage you to talk to your billers about this also, but frankly, there are a lot of ways to describe this. And then when we talk about commercial payers, because there are people that are following suit from what CMS is doing because of the pandemic, and there are modifiers that typically one would require. And so I would encourage you or your biller to contact them to make sure that you're doing it appropriately. But there is going to be some laxity associated with the coding of this as well. So this is a brief summary slide looking at the virtual check-in versus the e-visit versus the telehealth and the codes that one can use, along with a reference to CMS kind of surrounding this general information on telemedicine. And then this summary slide, I think, accomplishes a lot, which lets you know, frankly, what audio-video communication is required for each type of service, along with the type of relationship that you need to have with the patient, along with the codes that one can use to, again, better care for our patients during this time where we need to be physically separated, but then showing them that they're not socially isolated, that we are providers that are here to help them. We've been doing that for a number of years, and we want to make sure that they feel supported during this time when there's such psychological distress. So with that, I'll turn it back over to Dr. Deere.
So we have about 20 minutes left. And in that 20 minutes, we're going to cover one of the most important topics that I've been asked recently. What do we do when we define elective, urgent, or emergent cases? Because we're trying to be responsible, but we have other issues with our patients that we want to maintain their health while we protect them. So it's a really difficult balance. We've asked two of our colleagues, Dr. Syed, Dr. Peterson, to guide us through that discussion. And again, this is one of, I think, the most important parts of this whole webinar. So Erica, Dawood, the floor is yours.
Thanks, Tim. So I think, one of the things that I've been getting questions from just here locally at our health system, and to pivot back, I personally work at a tertiary academic medical center. We work in a multidisciplinary spine center. We have several orthopedic and neurosurgeons in our center, as well as 7 pain practitioners, physicians, nurse practitioners, physiatrists, neurologists, and psychiatrists. We're all kind of grappling with how to address, these thousands of patients that come through our doors every month, and our world has really changed quite drastically in 7 days. So I will also give myself a little bit of a disclaimer that everything that I may say and the thoughts and views I have today could completely change in 24 to 48 hours, depending on where this pandemic goes. So again, for how does an interventional pain proceduralist or interventional pain physician handle their patient population at this time? Elective versus urgent is a significant challenge facing all physicians, and Dr. Erica Peterson will talk about the specific challenges facing her as a neurosurgeon. Pain procedures can be seen by many as elective procedure, but really, on the other hand, pain procedures can also be seen as urgent by most patients and many clinicians. I'll give a personal example. On Monday of this week, we were kind of grappling with how to deal with our pain patients within our practice. So our schedulers called about 500 patients that were on our schedule over the next week between all of the providers. And we said, for pain procedures, we will give the patient the option. If they think that their pain is severe enough where they would require them to go to the emergency room, that they should go ahead and come in for their procedure. We were a little bit shocked by the response that we got. Out of the 500 patients that we called, 450 of them said that their pain was so severe that they would go to the emergency room if we did not do their procedure. So it really didn't make a big dent in us trying to, practice social isolation and trying to, flatten the curve as we're trying to do here in Kansas City. So we've had to kind of change our strategy a bit as well. And when we talk about our pain procedures for our patients, we talk about this as clinicians as elective and non-elective, but for most of our patients, they think they're very necessary. They don't look at these procedures as elective when they're in severe pain. So we're grappled with quite a bit of challenging situation here. And again, one thing we always have to keep in the back of our mind that most of the patients in our populations are greater than 65 years of age and have underlying conditions. Next slide, please. Can you go forward? Next slide. So one thing I'd like to share with you, there has been some guidance on this. So CMS just last week published some guidance, previous slide, on how to tackle this situation of elective procedures and surgeries. So again, what they propose is a tiered system, tiering procedures from tier 1A all the way to 3B. Pain procedures can potentially fall in a few of these buckets. One thing I think we need to think about when the patients that we are going to proceed with is in that tier 3B or 3A. These are patients that are highly symptomatic. So highly symptomatic patients, the guidance right now by CMS is to proceed with those patients, proceed with their surgery or their procedure. So again, we do have to make our best clinical judgment. I think my best advice for people right now is to take it on a patient by patient basis. There's really no full guidance that we can give you. Is it okay to do an epidural steroid injection? Is it okay to do an RFA? Is it okay to do a spinal cord stimulator trial? I think that's all going to change, and you have to weigh that based on the certain position that patient's in. Next slide. So there's also a lot of other implications besides that. We know that we're faced with a nationwide shortage on PPE. So one of the things why we decided to shut down our surgery center in our institution was that we really had to shift our PPE to the hospital where they're trying to take care of patients with COVID and COVID rule out. So that was really the reason what happened to us on our local level when the decision was decided to shut down the ambulatory surgery center. We still need to be aware of the downstream risks of increased healthcare utilization for not performing pain procedures in patients with uncontrolled pain. Will these patients eventually show up to the emergency rooms? Will they take increasing doses of pain medications and cause other unintended consequences? So we have to be hypervigilant and aware of all these things as we make these decisions on a day-to-day basis. How are we going to manage our patients with implanted devices, patients with intrathecal pain pumps or baclofen pumps, patients with implanted neurostimulators? I think we're going to have to figure that out together over the next few weeks and months. Again, like I said, this will likely evolve. We need to take precaution and evaluate each day differently and each patient by patient. I think I would also preface this, you have to really be aware of your local environment. So, the guidance that, ASPN may provide, it may not portend or be relevant to someone that practices in New York City. It could be very different for someone in West Virginia, where the numbers of cases are significantly lower than other places in the country. I do pledge that our ASPN COVID work group is working on providing more granular guidance for the medical community on interventional pain procedures and neurosurgical procedures. Again, we're going to try to take be careful with our guidance, not to be overly prescriptive. I think this is really one of those times where physicians have to make their best clinical decisions. With that, I'll pass it over to my renowned colleague, Dr. Erica Peterson.
Thank you, Dawood. I think that the key on this is that all of a sudden what became a physician-patient discussion about the risks and benefits of the procedure and whether to undertake a procedure that we recommended was worth the return on the risk, now is an expanded discussion. You not only have to balance the clinical scenario of the patient and what you would offer in optimal times, but it's on our shoulders as the clinicians to now think about the risk to the clinician team. For example, any intubation is a case of aerosolized particles, and now the entire surgical team, including the intubating anesthetist, will be at risk of exposure. And as Dr. Nadu and Dr. Marcellin both said, we have to presume that every patient that we encounter may be an asymptomatic carrier or infected, and therefore we will compromise a surgical team. The other component of this is to think exactly about the local health system and where the greatest public need is, and that includes the need for personal protective equipment, for filtration and respirator equipment, and even for endotracheal tubes and ventilators at this point. To that end, we are working on a white paper. The American College of Surgeons has done a similar thing this past week, where they've suggested that appendectomies and cholecystectomies be deferred, and that wherever possible, medical management or percutaneous cholecystectomy tubes should be placed rather than doing open procedures. And I think that there will be a consideration that we all need to make, particularly in looking at patients that fit into a tier 3A situation. Obviously, emergencies And those patients who are lower risk and who can be addressed outside of a main operating room may be patients who are amenable. But even in the situation of a patient who says that their device has not been working well and they'd like to meet a company representative for reprogramming, industry partners, including the manufacturers of spinal cord stimulator devices, are all providing guidance to their on-site clinical support teams as to how to interact with patients in this time. And distance in order to manage a device, interrogate a device, to meet and make sure that we're maintaining all of those safeguards that Dr. Nadu has already referred to is essential as part of this. The evolution here is quick. I recommend looking at the CMS guidelines and what these tiers are, and then applying that to your own practice, and then looking forward to what we in ASPN will be introducing in terms of some broader thoughts in the next week. Tim, back to you.
Well, thank you, Erica. Today, I had two important meetings on studies I'm the primary investigator on, where we had the dilemma of what do we do with the 6-month visit, the 1-year visit, the 2-year visit? What do we do? Because we want to keep our research whole, make sure it's impactful, make sure that we continue to build evidence. At the same time, we want to keep our research coordinators, our patients, and our nurses safe. So this discussion is very important, I think, for those in research. So Krishnan and Erica, please guide us through a brief discussion of that issue.
Thanks, Tim. I think this is a really important issue too. For at least I can tell you anecdotally at UCSD, we had on active about 10 to 15 active trials that have now been currently put on hold. I would really recommend for a lot of the folks on the webinar today to look at the FDA recommended guidelines, and that helps you start to tease out the process of which study to continue, which ones to put on hold as this kind of the situation on the COVID-19 develops. But it also really, they've given some guidance on should we be re-looking at these trials in terms of the current situation. So the first and foremost, I think the key take-home point is patient safety. Above all else, whoever is involved in the trial, yourself as a principal investigator, your co-investigators and or your folks that are working as a study coordinator and people that are recruiting, patient safety is number one. And in terms of actually looking at the trials, should there be specific changes in the end outcome parameters that we're actually measuring? So are certain variables a necessity? Should we be looking at less things in the trial compared to things that we would typically measure on more clinical visits? These are things that you would consider. And as a member of the UCSD Institutional Review Board, I can tell you they are an outstanding resource, whether you're using WERB nationally and or an institutional IRB, please consult them. They have a lot of guidelines that are coming down on a state-by-state basis, on a national basis that can help you figure out what trials to do, what changes you need to make. As I stressed at the very beginning, patient safety is number one. On the right side, this was actually recently put out by our decision tree at UCSD in terms of kind of looking at how do you approach these type of trials in this current situation, really looking at safety of the clinical research. Can portions of the study be done remotely? I know Jason had given us an excellent overview of how to implement telemedicine on a clinical visit perspective. Can we implement that within the study design? And we have to be mindful that the outcomes that are coming from that are going to be different than a traditional trial that you would be running at your place that doesn't have the current limitations on social distancing as well as contact with the patients. And certainly be mindful of all of the recommendations with the PPE, all of the other aspects of what resources you're using. So it is a difficult time. I think work with your sponsors, work with the IRB. They all have excellent resources for folks that are on the call today in terms of what to do with the clinical trial component of where we're dealing with this whole COVID-19 issue. So Erica, any other thoughts?
Yeah, I just echo that we are having a very similar experience at the University of Arkansas here in Little Rock. And I'm a national advisor on a few studies where we've had these same discussions through the protocol development. some real creative solutions, including doing open air drive-through follow-up visits, as well as tele visits, where they're mostly questionnaire-driven outcome studies, which may apply if those protocol variations can occur. But this really puts things in flux, and I think that when these research studies are ultimately presented in the next year or two, we're going to see an asterisk in the results table saying deviation or perturbation due to the COVID window here, if we're able to conclude them. I've also been part of some discussions about studies that are going to be pausing enrollment or delaying the kickoff of enrollment because there are just too many questions right now. So the sands here are shifting quickly, and it's very important for all of us to put our energy towards patient safety and clinician safety in front of the research portion of things now.
Tim?
So last portion. So for those of you who stuck with us, I know we still have many people with us, but I do plan to write an article on research in the time of COVID-19, because I think it's a learning tool for all of us in future disasters for our country. So that's an article I actually am planning to write with some of my colleagues. Our last component here is, how do you stay healthy yourself? So Christian, I'm going to go to you first, and then I have my own thoughts.
Yeah, absolutely. You know, I think this is probably one of the most important things. I think as clinicians, we spend so much of our time focusing on our patients, focusing on our loved ones, our friendships, and we put us last in front of everybody else. And so often than not, through text messages, through folks that I've talked to, there's an immense amount of stress that can happen to you that you're not considering it. So if you could go to the next slide, I just want to present some of the stuff. I mean, I think we need to be mindful that very rarely do we get put in these circumstances, whether there are folks in the ED that are in the front line to, we actually have a faculty that has a dual appointment that's spending time in the ED as well as in the pain clinic. But just the exposure, the risk of potentially contracting the infection, the challenges from having access to specific equipment, as well as providing support for other medical folks that are in the front lines, as well as dealing with patients and staff, really brings a lot of stress for us. So what I think as a recommendation, if we could go to the next slide, we feel that there isn't an absolute right answer, but you got to make sure that you're taking breaks, you're connecting with your colleagues. I think between Tim, I, and a few of the folks on this panel, we text all the time. We really are communicating about what are the recommendations that are coming out, how best to implement that, really being a resource, and not just as friends, but as colleagues in a really stressful time, and really respecting differences. People have a difference of opinion, and we need to be respectful of that, whether you're in a private practice setting to an academic setting. We got to try to find a middle ground to meet folks halfway through and staying updated. And I do want to make a really important point. A lot of anxiety can happen with just looking at the amount of media. We're in the era of social media where you're getting instant amount of information that's constantly coming to you, and you're trying to filter through that. So be mindful that you look at that information, you qualify its reference, you at least validate it to the best of your ability, but certainly be mindful that that can also impact you. It can impact the way you're dealing with yourself, dealing with other friends, dealing with your colleagues. So make sure you check in, make sure you take care of yourself. This is not a quick sprint, this is a marathon. And Tim has been an avid person in exercise. He's been doing that his whole life. And in fact, he's convinced me to run to the best of my ability. But I mean, certainly, Tim, you could share some of your experiences with that, and as a kind of a way to de-stress.
Well, just a few thoughts. If you look at some of the literature on keeping your immune system as healthy as possible, which is important for all of us, exercise is a key part of that. So I encourage you to go out every day. If you're not a runner, walk. If you're not a walker, do some stationary bicycling in your home. It's going to help you mentally and physically. Your diet's very important. Blueberries, mushrooms, broccoli, all those things have been shown to boost your immune system, and you need that. Vitamin C, vitamin D, which you can get either by supplements or sunshine. All those things are very important. And the other thing I think is really important is to find some beauty in your life. You're staying home more now than ever, and you're going to see things with your family you haven't seen maybe in a long time and with your colleagues. So All those things are going to help you stay healthy, because if you stay totally stressed out about the situation, get no exercise, eat horribly, your immune system is going to suffer. So, Krishna, I think those are important things. And as you said earlier, we still share laughs in our most difficult times of stress. And it's important to find some joy out there in this terrible time. Just like love in the time of cholera, we're trying to find joy in the time of COVID-19. So with that, I want to have you have a few closing things, Krishnan, and then I'm going to go over just a few comments to finish the night.
Just want to say thank you for all those folks who attended the call today. We apologize for folks who couldn't get on. We're going to try to bring a recording and certainly try to get this information out. The most important thing that you're going to take away tonight is that this is the starting point of us helping you establish some resources. We're going to provide links to things that include what are the guidances from the big CDC, CMS, different resources, including telemedicine resources, as well as places that you can go to focus on your mental health. We are going to work to the best of our ability. Nobody has a crystal ball to know what the future holds in the next 2 weeks to 4 weeks, but we're going to try to help in providing the best granular guidance that we can, and hopefully we can work with each and every one of you to try to help you with your practice. So I'm going to go back to Tim at this point.
So, Krishnan, thank you. And just a final thought here tonight. We're planning, we actually planned on having, I thought we'd have 100 people, and our system can only hold 2,500 people, and we crashed the system. As you know, it messed up our audio for a while. It's coming back now, some I believe, but we're going to record this and probably re-record it and make it available very quickly to our members who could not get on tonight, because I know a lot of people tried to get on and couldn't do so. We're planning another webinar for our fellows and residents to talk about how, what's the implications here in your training, what's the implications here on your board certification testing, what's the implication here with you getting a job, because I know it must be very stressful right now if you have a job that's scheduled to start in July or August and you're worried about the practices you're joining, will they be able to afford to hire you? So there's all those stresses for our residents and fellows. Many of you sent in questions tonight. We're going to try to have another webinar to answer your questions with our experts. And lastly, I'll just ask each of you to go home tonight, or you're already at home, but as you go out tomorrow, I want you to think about really kind of what you can do to keep yourself safe, keep your patients healthy, and yourself healthy. Lastly, I want to really thank those who sponsored this webinar tonight. It's our corporate collaboration partners, because they care about the patients and they care about us. And I think that it really says a lot for our corporate partners to reach out and help us spread information. So I can't say how much significance there is in that. Lastly, I wish everyone good health. I wish everyone good practice and their safety precautions, and may God bless you. And we'll hope to see you again in another week or so for our next version of the COVID-19 Task Force ASPN PSPS webinar. Thank you for joining.
Yeah. I mean, it's just like, oh, I gotta talk to Emily about. So we're gonna not inform the staff that Nicole was, she's sick, obviously. She was sick all last week.
Well, I mean, that's what we know right now.
So-
She's sick.
If she was sick last week, and she was gone all week, right? So she was gone all last week. I'm just trying to think like what,
It's kind of weird. She was gone all last week and then